If okay, we will move on to Dr. Dilenge, who's here to talk about spasticity. The floor is yours.
If someone can, yes, okay. Sorry. All right. So yeah, I'm Dr. Dilenge. I'm a child neurologist. I used to work at the Montreal Children's, and my specialty is neuro rehab, so particularly cerebral palsy. And I'm with Dr. Filion, who is presenting later to do a multidisciplinary spasticity clinic, which is why I was asked to speak about spasticity. Thank you for the invitation. I have no disclosures. So let's start by talking about a few definitions. First, tone is the resistance to a passive stretch while the patient is attempting to maintain a relaxed posture. Hypertonia is increased tone that can be classified as spasticity, dystonia, or rigidity. So what is spasticity? It's a state of increased muscle tone. It's sustained, it's always there, and it disturbs muscle contraction to cause abnormal postures. It's usually associated with increased reflexes, clonus, or upgoing toes. If you heard the term Babinski, it's a lesion of the upper motor neuron, and the typical sign is a clasp knife sign for like you know, a pocket knife. When you open it, you feel the clasp or the resistant, and that's how you test for spasticity on examination. What's important to know, it's velocity dependent, so the faster you go, the more the spasticity is obvious. I won't go into dystonia so much because the next presenter, Dr. Meyer, will talk about other movement disorders. So I'm sure she'll talk about dystonia. But because in leukodystrophies, it's often a mixed pattern of movement disorders, it's important to make the difference between spasticity and dystonia because the treatments are sometimes different. So if we go over a little bit of anatomy, you see the pyramidal track, or if you you'll hear that if you talk about treatment of spasticity. It starts over the motor cortex and goes down and crosses at the upper spinal cord level in the medulla, and then goes down through the lateral cortical spinal tract to innerve the skeletal muscle. I won't talk about that. So the pathophysiology is usually that the normal brain delivers an inhibitory signal to the spinal cord. So that inhibitory signal modulates the reflex and the tone remains normal. When the brain is damaged, it could also be the spinal cord in some people, not in our case. It fails to generate the adequate inhibitory signals. So there's a lack of inhibition, and then therefore that leads to spasticity. How do we assess spasticity? Yes, you examine for spasticity, you look for the tone. The signs on exam is the presence of clonus. So when, for example, you bend the ankle fast, it goes and it does a few beats. That's called clonus. Babinski is an upgoing toe. Usually reflexes, the deep tendon reflexes are increased. It's velocity dependent. So the faster you move the limb, the better you're gonna feel the clasp knife or the increase in tone. It's usually not a sustained posture like with dystonia. And you can have increased tone also because you're in pain or because you have lesions. So be sure that there's no such thing that could fake spasticity. That's the Babinski. So when you scratch under the foot, the toes goes up. That's a sign of increased tone, while normally the toes go down. Typically, when you're spastic, you tend to have a posture of a limb. So your arm is going to tend to be flexed like here, It's going to tend to be pronated, so toward, like, rotate toward the inside. The wrist is going to be flexed. The fingers are going to be flexed. It's going to be hard to open your hand. And the thumb, instead of being out, is going to get stuck in your palm, and you can have a clenched fist. That's what you see in upper extremities when it's a bit more severe. And in lower extremities, usually it's stiff legs, straight, tiptoe walking, and scissoring when you walk. So you can divide the regional spasticity into different things, particularly in cerebral palsy. So if it's only on one side, you call it hemiplegia. If it's two legs, you call it diplegia, and if it's the forelimb, it's quadriplegia. It's probably less important to classify that in leukodystrophy, but it becomes important for rehab in cerebral palsy. So spasticity usually affects certain muscles more than others. It affects more flexors, adductors, and internal rotators. The spasticity also can vary. If you're more stressed out, it's going to increase, or sad. It can vary depending on your position and also depending on your state of alertness. In clinic, there are a few scales, but the one that's used the most often is the modified Ashworth scale. So you may see that in notes. It's a way for physicians or for therapists to grade the severity of the spasticity, so that from one time to the other, or if we start treatment, we can remember what we saw. Management of spasticity. So it's a step ladder approach. First and foremost, you have to remove pain, because pain may increase spasticity or dystonia. Then there's rehabilitation, and I'll talk about it later. Then you have oral medication, neurolysis, orthopedic procedures, and neurosurgical procedures. Medically, it's a medication either per mouth, like baclofen, I'll discuss about it later, or by injection, like Botox injections or phenol injections, or surgically by a baclofen pump. Selective posterior rhizotomy is not for leukodystrophies because it has to be on patients who are stable. Tenotomies is when you do you cut tendons, and that's an orthopedic procedure. So also remember that in leukodystrophies there is not just spasticity. There's many other movement disorders. Most of the data that I'm going to show about management now is related to cerebral palsy, but it can be forwarded to leukodystrophies as well. So what are the goals? Is to try to help the quality of life, try to maintain an adequate posture and musculoskeletal integrity, to diminish pain and lack of comfort, and to avoid contractures, so fixed joints. Also, it will have, the management is important to improve the functional ability and autonomy of the patient, to improve ambulation, to facilitate hygiene, and to ease the rehabilitation procedures. It's also a support to caregivers, because if the person is less stiff, obviously it's going to be easier to do the hygiene or to do the transfers, for example. In terms of rehabilitation, while it's stretching exercise, it's important to do exercise programs that the family can do at home or doing routine stuff, and also, once in a while with the therapist to review the goals and the programs. It's the earlier you start, the best it is, and to reassess frequently. Through that, you can get splints or ptosis, but also equipment such as wheelchair, walkers, or standing frames. It's important, as Dr. Daniels mentioned in his talk, to provide adequate sitting. It's the same for spasticity, and OT is important for feeding and fine motricity. We talk about oral medication. The most common is baclofen. Baclofen can be given per mouth or intrathecally, so around this, in the liquid around the spinal cord. It enhances GABA activity and therefore inhibits better. Benzodiazepine are also a good choice. The problem with benzos is that usually a patient gets accustomed to it and increases drooling and decrease axial tone. Tizanidine is not very used because it has a lot of side effects. It's used a little bit more frequently in the United States, but much less in Canada. Clonidine, I can't say that I've seen it helping. It's been helping through the baclofen pump in some studies. And dantrolene is not used anymore because it has potential harmful side effects. So baclofen is an anti-spasticity medication. It interferes with the release of excitatory neurotransmitters. The thing is, though, that it does not cross the blood-brain barrier well, and that's why some people will benefit from intrathecal baclofen. And unfortunately, often you need to use large oral doses. And this, because you have to use large oral doses, you have more potential to get side effects. The main side effects are drowsiness. It's a medication that applies to the whole body. So often if you're very spastic in the legs, but that you have low axial tone, well, it's gonna increase that problem of low axial tone. It increases drooling. It can make you dizzy. It increases the risk of seizures. It can give you nausea and vomiting and hypotension. Benzodiazepines such as Valium, lorazepam, nitrazepam, or clonazepam are all good. It depends a little bit on the physician what they prefer. But common to all, it can give respiratory depression. So if the person has apnea, for example, it's something to be careful about. It will increase drooling. It can give you drowsiness, and it can decrease your memory, particularly give you anterograde amnesia in the long run. I'm going to thank Dr. Filion, who's going to speak later because I stole his slides from a previous presentation. The other thing we can do is a local approach to the treatment of spasticity, so mainly with injections to go for the muscle or the limb that's showing the most increased tone. It's more local, so there's much less generalized side effects. So Botox, there are many types. It's a toxin, and it's the most potent toxin known to man. So it's used in minute amount in the injections. The mechanism of action is it blocks the release of acetylcholine at the end of the neuron so that the acetylcholine doesn't go to the muscle receptor, and therefore it weakens the muscle. It's very effective. It favors the growth and the stretching of muscle because it weakens the muscle so you can stretch better. And it's extremely well tolerated with very little side effects. So the advantages is that there's little or no pain. The pain comes from the injection itself, but once the injection done afterwards, there's no real pain. Some will have some pain from, like a vaccine, for example, for 24, 48 hours, but it's rare. It's easy to administer, and it's reversible, which means that the effect lasts between 3 and 12 months, and then after that you return. So if you don't get a good effect from from the injections, at least you know it's going to go away. You can vary the doses depending on how much you want to weaken the muscle. One disadvantage is that it's very costly. One bottle costs about $400, and often we need two at least, or maybe three. Phenol injections is basically something that's gonna destroy the nerve. It's mostly used for scissoring for adductors, but it has to be done under anesthesia because it's painful. It's cheap, which is an advantage, and the effect is much longer than with Botox. You can have sensory issues like dysesthesia, so painful numbness afterwards. And as I said, it requires a lot of cooperation because it's painful, so you need to do it under anesthesia. In terms of surgical option, you can have muscle or tendon surgeries, lengthening or transfer of tendons, neurectomy, which is basically cut a nerve. It's not done very often, or bone surgery. For example, if the femur is too rotated, then they can unrotate the femur. In terms of neurosurgical treatments, there's the baclofen pump. I don't think we use it, or at least at the Montreal Children's, I haven't seen it used in other patients than CP or very dystonic patients. I've never seen one with a leukodystrophy. The only one other than that was an écardigousière, and it didn't work. But I'll still present it for your interest. The baclofen pump we usually do for group 4 and 5 GMFCS, that's for cerebral palsy, but it's basically for patients with quadriparesis, so severe spasticity, who are dependent for all activities of daily living. Why we do it? Because you can give much bigger dose without too many side effects, because it's injected around the spinal cord and it doesn't go through the whole body. It improves the hygiene, improves the sitting posture, comfort in the wheelchair, and it will decrease the frequency of pain and dislocation. The contraindications, if there are other movement disorders, so in 4-H leukodystrophy, because there's a lot of tremor, it wouldn't be an indication unless you're at an end stage where it's a comfort way. And it basically is a pump that's implanted under the skin with a catheter that goes in the back and is put like a lumbar puncture in the intrathecal canal. The other thing we don't always think of is to treat spasticity, you also have to treat associated conditions that can increase it. So if all of a sudden your spasticity increases, you have to go around and see, are there more stressors? Are there pressure sores? Is it improper seating or positioning? Is there an underlying infection? And is there constipation? If we talk about other types of treatments for spasticity, I do use cannabinoids, but like pharmaceutical cannabinoids, not oil, not CBD oil, but there's very little evidence that it works in the literature. There's some evidence it may work for dystonia, but again, it's still not for sure. I think there was a question in the chat about horse therapy. I think it's for those that can do it, it's awesome because it's zoo therapy and it increases the axial tone. At the same time, it makes them less stressed. So I think it's a good non-medical approach to the treatment of spasticity or any other neurological problem with tone issues. And the other thing is hydrotherapy. because you're in a state of less gravity in the water, you can definitely stretch better the muscle. It's important that the water is warmer though than cold, because if it's cold, it will increase spasticity. So I hope I did a little summary of all of that. Thank you.